Greetings everyone, my name is Bashar Abdallah, PJY3 at Abu Dhabi Ophthalmology Program. I have a case of a 32-year-old male who had a 12-month history of slowly progressive bilateral upper eyelid swelling and proptosis. He was seen elsewhere and referred to us. He had no changes in vision, no double vision, no pain with eye movement, no retrobulbar pain, and his general health was okay. This is the patient at presentation. You can see the bilateral eyelid swelling and the proptosis more obvious on the right eye. We did imaging and it was bilateral lacrimal gland swelling, more in the right eye. And we also found inferior ophthalmic nerve enlargement. We went for biopsy and the specimen was characteristic histological feature of IgG4 related disease. He had dense lymphoplastic infiltration and increased IgG4 to IgG plasma cell ratio by 70 to 80%, increased IgG4 plasma cells, and this fulfills the criteria for IgG4 related disease involving lacrimal gland tissue. This is the histopathology report and staining for CD138 and IgG4. We started the patient on oral steroid, and this is the patient 6 weeks following biopsy and oral steroid. My question is, what would you do differently, and would you try other treatment other than oral steroid, and did you face any similar case with more orbital involvement?
For IgG4, it's known to respond well for steroids, so we can taper steroid over a long time and see. If it's recurred, you can use more or a different type of immunosuppressions. We had a patient who didn't respond to steroid, and we used rituximab and improved with rituximab. Most of the patients, I seen like 5 patients with IgG4. 4 of them respond nicely to steroid with tapering. They did well, no recurrence so far. And 1 we had to use the rituximab for.
I think they also need to be worked up very well by a neurologist and make sure that they have anything else associated.
So based on the CT scan, did you already have a differential diagnosis of IgG4 disease?
You mean after I saw the CT scan?
Sorry?
After we did the CT scan, yeah, we had different...
So you already had a working differential diagnosis, and yes, you can make out it's not just the intraorbital nerve, neurovascular bundle, even the extraocular muscles were thickened and enlarged, right?
Yes.
So you chose to go and do a biopsy of the same side lacrimal gland?
Yes.
But you think there's pathology on the other side as well?
No, we did actually both sides.
We did a biopsy of the lacrimal gland of both sides?
Of both sides.
Do you normally do that, or?
Yes.
Right. Anybody else who does that? Somebody who's got bilateral lacrimal gland swelling, which is not a dacryoadenitis, say even lymphoproliferative disorders is in the clinical differential diagnosis. How many of you would do a unilateral biopsy? How many of you would do a bilateral biopsy? Show of hands. Unilateral, unilateral. Unilateral, okay, unilateral. How many of you would do a bilateral biopsy? Yeah, I routinely don't do a bilateral biopsy. I think you go for where the buck is, so I think you go for the unal side. But prepare the patient, but I agree with you the rationale, because every once in a while, you can get a reactive lymphoid hyperplasia on one side, or atypical lymphoid hyperplasia on one side, but the other side actually has a lymphoma. And you end up biopsying only one side, you actually end up missing the diagnosis of a lymphoma itself. And hence, there are some people who go ahead do a bilateral biopsy. So I agree with you. So, yeah. So.
What about if there's different diagnosis, the patient might not improve, then you might want to consider doing the other side. So I would start with one side, and if the patient doesn't respond, then I will do the other side.
Just before we close, I'd like to stress in the point Dr. Rahela mentioned, IgG4 is a systemic disease. That's why you call it IgG4, because of systemic association. So we need to send all these patients for systemic workup with a specialized specialty whenever you have like a hand, is it respiratory or abdominal or other part of the body involved. Thank you, Dr. Ashwal.